Welcome to the deep dive. Ready to plunge headfirst into ventricular arrhythmias?
Let's do it.
You sent us a ton of research on this, really diving deep into those 2022 ESC guidelines for managing ventricular arrhythmias, and especially all those tricky situations, the ones that keep even the experts on their toes, right?
You got it. It's a roadmap, helps us navigate all the twists and turns of ventricular arrhythmias, diagnosis, treatments, the whole 9 yards.
And before we get into the nitty-gritty, let's zoom out for a sec. Sudden cardiac death, or SCD, still a big problem. What's the big picture takeaway from the guidelines?
They hammer home that it's a multi-pronged approach. And one of the most fascinating things is that risk stratification. Really got to nail down who's at risk. And it's not just age or pre-existing conditions,
It's about the whole patient, right? The whole picture.
Exactly. Kind of look at everything, like family history, sudden cardiac death, especially if it happened young. That's a huge red flag.
It makes you think about those inherited cardiac conditions.
Yeah.
And those symptoms, those arrhythmic syncope, like fainting when you're working out or stressed, people brush those off, but they can be really important clues.
So we're piecing together a puzzle. History, family, those little symptoms. What else do we have in our detective kit? The ECG, obviously.
The 12-lead ECG. Oh, yeah, that's cardiology's best friend. Brugada syndrome, long QT syndrome. The ECG can point us in the right direction, and if we're lucky enough to catch an episode, bingo. We can nail down the type of ventricular arrhythmia.
It's like seeing that electrical storm inside the heart, right? But what about when the ECG doesn't give us all the answers? Like if someone has symptoms that come and go.
Ambulatory ECG monitoring to the rescue. Holter, event recorders, we've got options. Depends how often those symptoms pop up. These things are lifesavers, catching those sporadic blips we'd miss on a regular ECG.
Technology helping us peek under the hood. And imaging's got to be a big part of this too. Huge. Imaging helps us see those structural heart problems that can fuel ventricular arrhythmias. Echocardiography is a good starting point. How are those valves doing? Any wall motion weirdness? Cardiomyopathies.
And when we need to see even more, there's cardiac MRI, right?
Cardiac MRI, game changer. Gives us that fine-grained detail about how the heart's built and how it's functioning. Size of the ventricles, wall thickness, even those sneaky scar tissue patches that can set the stage for arrhythmias.
You mentioned genetic testing before. Seems like that's becoming more and more important these days. How does it fit into all of this?
It's playing a bigger and bigger role. Genetic testing can uncover those specific gene mutations that make someone more likely to have ventricular arrhythmias. It's especially valuable when we suspect something like hypertrophic cardiomyopathy or long QT syndrome, those inherited conditions.
It's like another puzzle piece, right?
Yeah.
Knowing someone's genes helps us predict their risk and plan their treatment better.
Exactly. And for family screening, huge. If we find a specific mutation, we can check family members to see if they're carrying the same risk.
Wow, we've already covered so much. Sudden cardiac death, the importance of digging deep into history and symptoms, ECGs, those ambulatory monitors, imaging, even genetics. Now, let's get to the main event, ventricular tachycardia.
Let's zero in on those types of VT that often give us a run for our money in the hospital. Monomorphic ventricular tachycardia and polymorphic VT, which includes that tricky torsades de pointe.
Monomorphic, that's the one with that steady, repeating electrical pattern, right? And polymorphic's more all over the place.
Nailed it. Monomorphic, those impulses all start from one spot in the ventricle, so that ECG pattern's nice and regular. Polymorphic, multiple starting points, so the ECG looks all twisty-turny.
And torsades de pointe falls under that polymorphic umbrella. Why is that one such a headache?
That classic twisting pattern on the ECG often comes with the prolonged QT interval. The tricky part is, so many things can trigger it. Electrolytes out of whack, certain meds, even inherited conditions.
So it's a bit of a chameleon, huh? Different looks, different causes. Must make treatment a real pain.
Big time. Managing torsades de pointe means tackling the arrhythmia itself and whatever's setting it off. Hypokalemia, hypomagnesemia, go fix those. And any meds that might be contributing, off they go.
Okay, let's say we've got a patient diagnosed with ventricular tachycardia. What are those first steps in managing them?
Hemodynamic stability, that's always step one. How's their blood pressure? Are they with it, talking to us? Or are they crashing, altered mental status, maybe even cardiac arrest?
So how well they're handling the arrhythmia tells us how urgently we need to act.
Exactly. Stable patients, we can take a breath, figure out what's causing it, start the right meds. But unstable, time is muscle. We got to stabilize that rhythm and stop things from going south.
So let's talk about those life-saving moves. Unstable VT patient, what's our go-to?
Synchronized electrical cardioversion, STAT, controlled shock, time to their own rhythm, hopefully resets the system and gets them back to a normal sinus rhythm.
Like hitting the reset button on their heart's electrical system?
Yeah.
And meds are in our arsenal too, right?
Medications are crucial, both for stabilizing the rhythm and keeping it stable. Amiodarone, that's a powerhouse antiarrhythmic, often our first choice. It tackles a wide range of ventricular arrhythmias, monomorphic, polymorphic, you name it.
I've got to admit, amiodarone always makes me a little nervous. Lots of potential side effects, right?
It's strong stuff, definitely has its downsides, so we use it carefully and watch our patients like hawks. But in those acute situations, when it's life or death, the benefits usually outweigh the risks.
What about dosage? Especially when it's an emergency.
Dosage always depends on the situation. Unstable VT, the guidelines recommend a 150 milligram IV loading dose over 10 minutes, then an infusion of 1 milligram per minute for 6 hours. After that, we switch to oral, usually 200 milligrams 3 times a day for maintenance.
So hit it hard initially to get control, then taper down to keep things in check.
Right on. And we're watching their response the whole time, tweaking the dose if we need to, always on the lookout for side effects.
So we've got electrocardioversion and amiodarone for those urgent situations. But what about the long game? Implantable cardioverter defibrillators, or ICDs, those come into play here, right?
ICDs are amazing. Revolutionized how we manage those at risk for sudden cardiac death. They're like little guardians implanted under the skin, constantly monitoring the heart rhythm. VT, ventricular fibrillation. ZAP, shock delivered, normal rhythm restored.
A bodyguard for the heart, always on duty.
Love that analogy. ICDs are a safety net for high-risk patients, and they really do slash that risk of sudden cardiac death.
This is all fascinating, but we've only just scratched the surface.
We have. There's so much more to uncover, especially how to manage specific types of ventricular tachycardia and those tough cases in certain patients. But before we get into all that, how about a quick break?
Okay, so we've laid the groundwork, talked about those emergency moves for ventricular tachycardia. Now let's put it all together. How did these guidelines actually play out with real patients? Different situations, different challenges. I like it, bringing it to life. Let's start with something we see all the time in the hospital. Acute coronary syndrome, ACS. You've got a heart attack, already a critical situation. How do ventricular arrhythmias complicate things?
Ventricular arrhythmias, they're a real threat in ACS, especially with the STEMI, that ST elevation myocardial infarction. The guidelines are crystal clear. Get that blood flow back, ASAP, PCI, fibrinolytics, whatever it takes.
So first things first, tackle that heart attack head on, limit the damage. But what about those arrhythmias? We're managing them at the same time.
Absolutely. Got to juggle both. While we're opening up those arteries, we got to keep an eye out for those arrhythmias. Electrolytes can go haywire in this setting. Hypokalemia, hypomagnesemia, those can trigger ventricular arrhythmias.
So it's like two battles at once.
Yeah.
Fix the heart attack, stabilize the rhythm. What about meds? They come into play here too, right?
You bet.
Yeah.
Beta blockers are a must. Keep that heart rate under control, lower the risk of those rhythms coming back. And if we get hit with sustained VT or VF, back to our old friends, amiodarone, and maybe even electrical cardioversion.
All hands on deck. So we've stabilized them. What about the long term? These patients, they've had a heart attack. Are they at risk for future arrhythmias? What do the guidelines say about that?
Risk stratification after ACS, that's key. Got to know what we're dealing with. Left ventricular ejection fraction, LVEF, that's our bread and butter, tells us how well that heart's pumping.
So we're seeing how much that heart took a hit,
Yeah.
how it's bouncing back.
Low, LVEF after a heart attack. Red flag. Higher risk of ventricular arrhythmias down the road, maybe even sudden cardiac death.
And that's where ICDs come in, right?
Bingo! LVEF really low, below 35% usually, and it's been at least 40 days since the MI. Guidelines say consider an ICD to prevent sudden cardiac death, primary prevention.
40 days. That seems specific. Any reason for that?
Yeah, gotta give that heart time to heal. Putting in an ICD too soon within those first 40 days hasn't shown much benefit. Could even put them at risk unnecessarily. It's all about finding that sweet spot.
Even with all this tech, we still got to respect how the body heals, huh? Okay, so that's acute coronary syndrome. What about chronic coronary artery disease? People living with CAD. What do the guidelines say about ventricular arrhythmias in them?
Chronic CAD, same story. Risk stratification is king. We look at that LVEF, see if they're having any non-sustained VT on those monitors. Even check if we can trigger VT during an electrophysiology study, see how electrically stable they are.
So same idea as post-heart attack folks. Find those who are at risk, those electrical time bombs.
Yep. And based on that risk, we decide what to do. Meds, lifestyle changes, maybe even an ICD if they're high risk.
Okay, let's shift gears a bit. Idiopathic ventricular tachycardia. Always found that one interesting. Idiopathic, what's that really mean?
Idiopathic VT, that's the head scratcher. VT in a structurally normal heart. Imaging shows everything's hunky-dory, but they're having these dangerous rhythms.
A perfectly healthy-looking heart throwing these electrical curveballs.
Exactly. It's a real puzzle. We got to rule everything out. Subtle electrolyte problems, thyroid issues, even those inherited channelopathies. Genetic testing can be helpful sometimes, but often we're left scratching our heads.
So how do you treat something when you don't even know what's causing it?
It all depends on how bad the symptoms are, how often they're happening. Sometimes just reassuring the patient and watching things is enough. Some people do well on meds like beta blockers or calcium channel blockers, keep those arrhythmias at bay. And for those with really frequent or troublesome episodes, catheter ablation might be the ticket.
Catheter ablation, going in and zapping those trouble spots, those rogue electrical pathways.
Right. Can be super effective for certain types of VT, including the idiopathic kind.
Okay, moving on. Cardiomyopathies. We know those are often linked to ventricular arrhythmias. The guidelines cover a bunch of them, but let's stick with dilated cardiomyopathy, DCM, one of the most common ones.
Dilated cardiomyopathy, DCM. Those heart chambers get all stretched out, weak, can't pump blood like they should, major cause of heart failure, and a big risk factor for ventricular arrhythmias.
So it's not just the irregular beat, it's that the heart can't do its job, pump that blood through the body.
Right on. And the guidelines make it clear, got to manage both the arrhythmias and that underlying heart failure.
What tools do we use to diagnose DCM?
Echocardiography, that's our go-to for DCM. Shows us the size and function of those chambers, checks the valves, gives us an idea of the ejection fraction.
Genetic testing probably plays a role here too, right? Lots of DCM cases have a genetic link.
Absolutely. Genetic testing is becoming more and more important for DCM. Confirming the diagnosis, screening families, it's got a lot to offer.
So we've got a DCM diagnosis. What's the priority?
Mm.
How do we keep those ventricular arrhythmias at bay?
Risk stratification, always. What's the LVF? Any non-sustained VT on the monitor? What's the overall clinical picture? Then we tailor the treatment. Meds, lifestyle changes, maybe an ICD if the risk is high.
Same approach, really. Assess the risk, treat accordingly. Meds. What's their role in managing DCM?
Meds are fundamental. We use them to control those heart failure symptoms, help the heart pump better, and squash those arrhythmias. Beta blockers, ACE inhibitors, ARBs, those are common. And if the arrhythmias are stubborn, we might add amiodarone or other antiarrhythmics to the mix.
You mentioned another one earlier, arrhythmogenic right ventricular cardiomyopathy, ARVC. What's the deal with that one?
ARVC, that's a bit less common, affects mainly the right ventricle, unlike DCM, which usually hits both. ARVC, it's like the heart muscle gets replaced by fat or scar tissue, makes things electrically unstable, right for those ventricular arrhythmias.
So it's not just about weak or enlarged, it's about what the heart's actually made of.
Perfect way to put it. ALVC can be sneaky, hard to diagnose at first. We often see ECG changes, especially in those right precordial leads, and arrhythmias coming from the right ventricle. Imaging, especially cardiac MRI, that's key to actually seeing those structural changes in the right ventricle.
Diagnosed with ARVC, what's the game plan?
Number one goal, prevent sudden cardiac death. Lifestyle changes, like no competitive sports, that's a must for all ARVC patients. Got to protect that heart. Meds, like beta blockers, can help tame those arrhythmias. And high-risk patients often recommend an ICD.
Wow, we've covered a ton. Acute coronary syndrome, chronic CAD, idiopathic VT, dilated cardiomyopathy, even ARVC. But there's still more to dig into. You mentioned electrical storms before. Those sound pretty intense.
They are. One of the toughest things we face when it comes to ventricular arrhythmias. Definitely deserve a closer look.
Let's jump right in. What exactly is an electrical storm? Paint a picture for us.
An electrical storm or incessant ventricular arrhythmia, it's terrifying for the patient. Imagine VT or VF hitting again and again, needing multiple shocks from an ICD or even external defibrillation. It's relentless, absolutely exhausting.
The heart's just going haywire, not responding to anything. What's the first move when we see a patient in an electrical storm?
Guidelines say be systematic. First, fix anything that's reversible. Ischemia, electrolytes gone wild, maybe even a med side effect. Those can all trigger electrical storms, so gotta tackle those first.
Playing detective again, huh?
Yeah.
Find the root of the problem, that electrical chaos. What if those initial steps don't work? What's next?
Storm's still raging. Time for meds. AV, amiodarone, that's usually our first line. But other antiarrhythmics like lidocaine or procainamide might be options. We often use sedation, too, helps control the heart rate, calm them down, because these storms can be scary as hell.
Pulling out all the stops. What about those advanced therapies? Sometimes we got to go beyond meds and sedation, right?
Sometimes, yeah. Overdrive pacing, that's an option. Basically, we pace the heart really fast, try to override that messed up rhythm, and if nothing's working, if it's truly refractory, we might need to think about mechanical support. Intra-aortic balloon pump, maybe even ECMO, extracorporeal membrane oxygenation, to help the circulation while we try to get that heart rhythm under control.
It's amazing what we can do now. But preventing these storms in the first place, that's got to be the ideal.
You got it. Careful risk assessment, manage those underlying heart problems. That's key to preventing those storms. And ICD programming, got to pay attention to that too.
ICDs, those life-saving devices. So it's not just implant and forget.
ICDs are lifesavers, but they're not foolproof.
Yeah.
One of the trickiest things is making sure that device therapy is appropriate. We only want it shocking for truly life-threatening arrhythmias.
Right. We don't want it going off for nothing, making them uncomfortable and anxious.
Yeah.
How do you make sure it's programmed right?
It's a balancing act. Got to set the right detection thresholds, the therapy zones, so it only kicks in when it absolutely has to. There are algorithms and features that help tell the difference between ventricular and supraventricular tachycardias, so it doesn't shock for rhythms coming from above the ventricles. And, of course, educating the patient, making sure they understand their device, what to expect.
It's like they're learning to live with this new piece of tech. It's part of them now.
Exactly. It's a team effort, the patient, the device, and us, the healthcare team.
This has been incredible. We've learned so much, from the basics to those really complex cases. I feel like we could keep talking about this all day.
Oh, we've only scratched the surface. But I think we've got a good handle on the ins and outs of ventricular arrhythmias, how to approach them in the real world.
Yeah, it's been quite a journey from those emergency situations, those code blues, to the long-term strategies trying to prevent sudden cardiac death. Ventricular arrhythmias, they really keep us on our toes, don't they?
They do, and these guidelines, they give us that solid foundation. But they're not set in stone, you know.
Right. Always got to keep learning. New research is coming out all the time. We can't just memorize the guidelines and call it a day. Got to stay curious, stay up to date.
Exactly, and that's what makes it so exciting. Those unanswered questions, those gray areas where you got to use your judgment, your experience, that's where the real thinking happens.
Thinking about our listener out there, someone who's clearly passionate about this stuff, what's the one thing you want them to take away from this deep dive?
I'd say don't just see these guidelines as rules. See them as a starting point, a jumping off point. Something piqued your interest today. The genetic testing stuff. ICD programming. Go explore it.
Become the expert. Challenge those old ideas. Question everything. Add to the knowledge.
That's what's so great about cardiology. We're always pushing the limits, and every one of us can contribute to that.
It's been a wild ride, exploring the world of ventricular arrhythmias. We've covered a lot, but it's just the beginning, isn't it?
It is, for all of us. And remember, knowledge is power, especially when it comes to saving lives. So keep those brains sharp and those hearts beating in rhythm.
That's a wrap on another deep dive. Thanks for joining us.